Hi, my name is Paola Muggia. I'm the Executive Director of the Chemotherapy Foundation. This is our third episode in our We Speak Cancer podcast, and I'm very excited about today because we have a very special guest and chair of our Medical Advisory Council, Dr. William O, who is the Director of Precision Medicine at Yale Cancer Center. So, actually, before I dive into some questions, I'm going to let Dr. O introduce himself.
Well, hi, Paula, and thank you for allowing me to come on this podcast. It's a really exciting initiative, and I'm really happy to dive into a lot of the exciting areas in terms of cancer research and cancer advances for the audience. I mean, my background is simple. I'm a medical oncologist. I now have been in practice for almost 30 years, which is kind of crazy. And during that time, I've seen a lot. And I started in the field partly because I thought there were so many opportunities to improve outcomes because when I was a trainee, many cancers had no treatments or very few treatments that could improve survival. And now that's turned on its head, and there are many, many excellent treatments that can not only keep people alive longer but better. But we still have a ways to go because cancer still is a leading cause of death and suffering, and we need to continue to keep the pressure on.
I wanted to talk to you about precision medicine and some of your key goals, objectives in that area.
Well, what precision medicine means is, you know, giving the right treatment to the right patient at the right time. That's one definition you'll often hear. And of course, we always want to give the right treatment to the right patient. And we've been doing that even before we had very good treatments. But chemotherapy is a good example of a treatment that's not particularly precise. In fact, when I was a trainee, there was a big advance in chemotherapy, a drug called paclitaxel. And when those drugs came around, we gave it to a lot of people. It worked in lung cancer, it worked in prostate cancer, it worked in breast cancer. So how could one drug work in so many different diseases? Well, the way it works is it kills rapidly growing cells. And cancer, one of the things that ties together all cancers is that they proliferate or grow in an uncontrolled way. That is a core definition of cancer. The problem is that it doesn't help everyone. And of course, it hits a lot of normal cells. It The best example of that is it hits fast-growing cells like your bone marrow, your blood cells, so that you may become anemic or your white blood cell count might go down. Or it affects the other cells that grow in our body, like our hair. Our hair follicles are always growing. That's why we need haircuts. And so those are some visible examples, but it's just not targeted enough. So the idea of precision medicine really began in earnest when we started to be able to sequence the human genome, which was about 25 years ago now. And we recognized that once we understood the underlying drivers of cancer, really, at least starting with the Human Genome Project, understanding the genetic makeup of both normal cells, but also of what goes wrong in those cells, we could start to develop drugs and treatments that target the specific mutations or abnormalities that happen in cancer patients. And that is the concept behind precision medicine for cancer.
Yeah, that would be a huge breakthrough. You mentioned paclitaxel, and of course, I was on that. And yes, my blood count got totally impacted by that. And I was anemic for a time. Now that I'm off of it, I am sort of like coming back, but it's not an easy drug to tolerate for a lot of people. I wanted to talk about some of the tools that you're using for precision medicine. You've been talking a lot about AI, and I have to say that I'm really fascinated at, you know, how that can be utilized. I know there's a lot of controversy around it, but could you talk a little bit about how AI is currently being used to treat patients?
Yeah, so what do we mean by AI in cancer? We all know that you can type in now to Google or ChatGPT, you say, who sang this song or who won the uh, Oscar in 1997, and it'll find it just the way Google used to find it, but maybe it can do it in a more directed way. AI in medicine and in cancer in particular is starting to do something more. It's starting to take all the information out there and put it into a form that may or may not be reliable to help doctors make better decisions or to educate patients. I think you still have to be careful. It's not quite ready. But there are companies and there are academic centers like ours that are building tools to both educate but also help to make some of these decisions that are more accurate for each patient. Um, so, for example, uh, in radiology is one field where AI tools are already fairly widely used. I I can tell it through an example. I saw a patient a few years ago, and I saw him, and there was a report, and I reported out his scan results and looked good, and I sent him home. And then the radiologist called me and said he ran the scan through an AI program. Basically, the computer then read the scan after he did. Now, I think he was supposed to do it in the other direction,
Yeah, yeah.
but it found a blood clot in his lung that this very experienced radiologist did not see.
Wow.
So I had to call the patient back and said, there was a computer program that read your scan after the radiologist did and found a blood clot. And I started him on a blood thinner. And, you know, human beings are, we're flawed. A doctor, I don't blame a doctor who sits there and reads 20, 30, 50 scans, but just like an airplane, we expect perfection. We do
Right.
not want to miss anything. So computers can help a doctor, in this case, a radiologist, see what he or she may not be able to see. So that was a very, very concrete example of how that kind of AI tool, which is a visualization tool, can help. There's another tool in my field. I'm a prostate oncologist, as you know, that is taking AI to a different level. So when a man comes in with prostate cancer, I have different pieces of information that can help me to know what type of prostate cancer he has. We have a PSA, we have a Gleason
Mhm.
score, which is what it looks like under a microscope. We have staging information. But those scores and those pathology grades are actually, again, read by a human. And they're big categories. They're big categories. So in this case, a patient had a Gleason 7 prostate cancer, which is considered an average cancer. Could behave well, could behave poorly. So we can run these additional tests, and there is a now a commercially available AI tool called multimodal AI, where again a computer just looks at the slide and it doesn't give it another score like a Gleason score like the pathologist did, but it gives it a numerical risk score, which it was trained on to say, you know what, this is going to behave better or worse than we think based on all the other patients with that same type of cancer, just based on the way it looks. And it's actually what we call a black box. Like nobody knows why it says that this looks more like the other. Like you can't look at the picture and a pathologist or a doctor can't look at the slide and say, I know why the computer picked this as doing better or worse, but we know that it's been validated and that it's now part of the guidelines. So that's an example of computers seeing things that we can't see. Now, those are just two examples, but
Yeah.
we're going to see more and more examples of this. Now, the real question that people don't know is, will it take me out of the equation? Will I no longer be making the decisions for my patients? And I don't think that's in the near future. Could it be in the distant future? I sometimes joke that, a person will come in and sit across from a robot or across from a computer, but I don't think that's going to be for now. And that's because these tools are imperfect. They're not ready fully, but they can supplement or help a doctor to make better decisions for their patients.
Do you think that there are many physicians using AI right now as a way to sort of in the examples that you just described, or is it still more of a smaller percentage of?
Very, I think it's very early right now. I
Okay.
think in the average cancer doctor's day, an AI tool visible to him or her is probably only a few percent of the time. In the radiologist's office, as I mentioned, which we may not see as you don't see the radiologist reading your scans, But in the radiologist's office, it may be much higher, that percentage. As I said, a lot of these programs are running in the background and helping the radiologist to make sure that they don't miss something. So there it might be more like, I don't know, 80, 90, 100% of the time they're using an AI tool. So we're going to see this more and more where um, even let's say you ask a question like how like sometimes a patient will say, "Okay, Dr. O, this is what you recommend. Are there any clinical trials for me?" Well, if I want to do that now, I have to stop, go to a computer, go to clinicaltrials.gov or some other database, type in the nature of the cancer, type in all of these other pieces, and 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 then I don't even know a lot about those trials. Maybe you're eligible, maybe you're not. Maybe they're open, maybe they're closed, but there are people building these tools so that, in a much more instantaneous way, we can give that information back to that person. So I think that as these tools get better, doctors will still be the filter
Right.
through which this technology is communicated through to the patient. But I think that it's going to make doctors, oncologists better at what they do.
Yeah. On getting back to precision medicine, do you see the AI as being sort of integrated into that whole process?
It is again on the back end. So for example, one of the things about being precise is it takes a lot of computing power.
Right.
Um, there are thousands and thousands of genes, and every time, let's say, a tumor tissue is run through a sequencing to try to understand the many genes that might be altered in a specific cancer, not all of them are relevant, right? There may
Right.
be dozens of genes that are altered compared to normal, and then they're run through programs to help define, again, using programs, but more and more using AI to say this is probably a relevant gene and this is probably not relevant. That is then reported out, and then a decision's made. And the question is, who makes that decision? Right now, it's me. I get a report that this tumor has four genes that are altered, and I have to make the decision. But in the future, I think, the problem is I have to make the decision with everything in my head and
Right.
typing into a computer and seeing what is this person's PSA, what is this person's age, what is this person's, um, other medical history. So right now, the computer is my brain, and and as I get older, even though I'm very experienced, I worry. I was like,
Yeah.
there's how much information can one person process? Now, I happen to only focus on one cancer, prostate cancer. That's my main focus. And but there are a lot of doctors out there who focus on 50 cancers. So how can one person with one brain focus on 50 cancers? Well, it's hard, right? Especially
Yeah.
because so much information, both about that individual patient, but also think about all the information coming in. It's not just the patient's genetics, but their other medical history, the medicines that they're on, the new data coming from a clinical trial that might have just been released last week. How does somebody keep track of all that for 50 cancers? Well, I think that's really hard. So I think the way that all of these tools, we have to think of AI as another tool. It's not going to take over. Robots are not going to come into our clinic and just start writing chemotherapy and writing drugs. But but if we use it right, it'll be the way driving a car is today. You know, you and I drove cars a few years back. If we didn't have the all the safety features we have
Right.
now in a
Exactly.
car, and it makes driving a car much safer. But cars still get into accidents. Why? Because, well, sometimes people ignore it, or sometimes those are not fail safe. So I think that everything's about making the patient's outcome as good as possible. Everything's about patients. The patient has to be at the center of all this. I wouldn't use these tools, you know, just if it didn't help my patient in the long run. And of course, if it helps me to get, see more patients or to do a better job with of course I want that tool, but in the end, it's really to try to improve patient care.
Cancer treatment has definitely evolved and evolved quickly with some of these tools through, in the past 5 years. And it's pretty amazing. But what do you think that cancer treatment in the future will look like for a patient? I know it's all being better managed. There seems to be a little more access to clinical trials than there used to be. Um, all good
Yeah.
things. I'm just wondering how you see cancer treatment therapies impacting patients in the future.
As the cost of doing this molecular testing has gone down, I think everyone should get molecular testing
Yeah,
so that we understand as much as possible about each cancer. I think that we're not going to treat an individual cancer a million different ways. There aren't a million different drugs for each person.
right,
That's we want to pick the one drug that's going to have the best outcome. And if that outcome is to get rid of the cancer, that's what we're going to prioritize. And that is why, despite all the advances we've made over the past few decades, we still use drugs like chemo. Because one of the things about medicine and about science is you don't kick out an old treatment until you're sure that the newer treatment works better.
right,
Everything I just mentioned to you is fancy and cool, but if it's no better than what already exists, if it's worse, then we're not going to change what we do. So to answer your question more directly though, 10, 15 years from now, I think we're going to understand when a patient comes in with cancer, we're going to understand a lot more about what the nature of that particular patient's cancer is. And we're going to give them much more directed therapy. It's already happening.
yeah,
Precision therapy or targeted therapy means we're giving them drugs that work in their particular case. And why do I know that we're going to shift more and more to that? Chemotherapy is a very good example. We talked about it a few times. We're actually able to give chemotherapy more accurately. There's a whole class of chemotherapy drugs that are called ADCs or antibody drug conjugates. And what those are is chemotherapy, but stuck to a molecule that kind of is much more precise, like a smart bomb. Delivers the chemo right where it needs to go, not throughout your whole body. In that case, it does a lot less of the things we don't like chemo to do, like to have effects on the blood cells or the bone marrow or fatigue or hair loss. Does it still have some of those effects? It could, but the two things happen. The effectiveness of the drug goes up because you're actually delivering the chemo right to the source of the cancer, and so less of it goes to where you don't want it, and more of it kills what you do want to kill, which is that bad cancer cell. So, but not only ADCs, there's a whole bunch of other ways of delivering the treatment more accurately. And it is a form of precision treatment. So, for example, there's something called radioligand therapy or for theranostics. You'll hear different names for it, but it's a similar idea. You do a smart bomb technology, you know that this cancer cell makes a molecule like HER2 or PSMA or some other molecule that we know is primarily on the surface of the cancer cell, and you attach it, in this case, to a radioactive particle, which is a radioactive payload. And you're kind of throwing a radioactive payload, almost like intravenous radiation, directly into the cancer cell, adjacent to the cancer cell. That's working too. And there are
that's
drugs that are already available to do that. And there's a whole bunch of drug companies that are trying to develop new drugs, new payloads, radioactive payloads, and also, uh, new targets. So that's why knowing where the cancer cells are hiding, you might say, well, why are they hiding? Well, because you want to leave your normal cells alone, and these cancer cells, what makes cancer cancer is that they can spread, and you want to attack them and kill them where they are, wherever they are in your whole body. So that's why radiation works if the cancer is only in one place. We radiate patients all the time. But if the cancer is not in one place, you can't radiate all the different places it goes to. You need something that goes to where the cancer cells are. And the third I'm just going to mention quickly is uh, immunotherapy. Now, we know immunotherapy works broadly in a lot of cancers, like melanoma, kidney cancer, lung cancer, but it only works for a subset of patients. So when you give an intravenous immunotherapy drug, so-called checkpoint inhibitors, it
mhm.
can kind of rev up your whole body's immune system and take the brakes off the immune system, and it goes and attacks cancer cells wherever they are. And it really works well, particularly in melanoma, but it doesn't work in the majority of patients. And there are many cancers where it doesn't work really at all by itself, like in prostate cancer. So there are classes of new targeted immunotherapy too. One approach is called bispecific molecules. And what bispecifics are is the same idea. Like if you think about it, they're all very similar ideas. They're trying to
Yeah.
deliver something to the cancer cell more directly. And in the case of bispecifics, it's an antibody where one side is targeted to that cancer cell and the other is to a T cell. And a T cell is the action part of your immune system. That's what kills cancer cells. So you're introducing the T cell, like matchmaking the T cell directly to the cancer cell. And those bispecifics seem to be very promising. We keep seeing studies that show that it works, but they have side effects too. So all of these, by the way, have side effects. So what we have to do in clinical trials is kind of make sure the benefit way outweighs the risk. And remember what I said earlier, that it works
Yeah.
better than the ones we have. Like it's just because it sounds cool doesn't mean anything until it really shows, until we prove that it really works better than what we already have.
I mean, I know that when I was having chemo, of course, it had a cumulative effect. Every round would get more, seemed to get stronger and stronger, but there was also sort of a timing release element to it. So I could tell there was some sophistication to just the chemo drugs I was getting. Very fascinating. If we look at back in the 1960s when Ezra Greenspan, who was the founder of the Chemo Foundation, was, you know, experimenting with combinations in order to treat his breast cancer patients. And now it's I think I can put the tag of progress really on it. I know that President Biden has been in the news, and he is was diagnosed with stage 4 metastatic. And what I've been reading is that his prognosis is actually pretty good considering the drugs that are out there. So I was wondering whether, you could talk about just prostate cancer advances in that area and, directly how it relates to President Biden and what he's going through right now.
Yeah, there's a few different things about his case that are very illustrative. The first I'll comment on is he apparently by report he hadn't had a PSA test in 10 or 11 years.
I
And
heard
that's
that.
because the U.S. Preventative Services Task Force explicitly recommends against PSA testing after the age of 70. But of course, you're going to hear me say I don't agree with that recommendation. And the reason I don't agree with that recommendation is because um, PSA testing, while it's not a perfect test, can help us to understand what's going on in that person's body. It is expected that that task force will actually change their recommendations this year. They're updating them now. But that data came from a time when we thought, well, you know, the man's old. Let's leave him alone. Let's not find a problem that we don't need to treat because many prostate cancers are very indolent. They grow very slowly and you may not need to treat them. But I think what we're seeing here is two things. One is men are healthier as they're getting older. So there are a lot of older men who are living better because cardiac care is better and they're exercising more and they're eating better. But also, we've learned something really important. We don't have to treat every prostate cancer, but we want to know the ones that are dangerous. And so there is a second piece of information that's important to this, which is we're seeing more and more metastatic prostate cancer. So the rates of metastatic prostate cancer, or the kind of cancer that has spread from the prostate to the bones or elsewhere, is going up over the past 5 years. Very concerning trend. And part of this we think is because a lot of men are not getting tested. When I first started in the field, we were seeing the metastatic rates go down because many men were getting PSA testing. And now we're starting to see it go up. And what that really means is finding the cancer and then the guys who have a slow growing, what I'll call a wimpy cancer, leave them alone. You can monitor them. But the ones who have the kind that might behave the way President Biden's is behaving, you have to do something first. And the goal is to not let it spread. So the second part of your point is, in fact, we do have a lot of treatments for him. I'm not his doctor,
Yep.
but uh, when I started out, if a man like in his early 80s presented with metastatic prostate cancer, we had hormonal treatment, and it would work for a few years. and then the cancer would start to grow, and there was nothing else we could do. That's what it was like when I was a trainee, when I first started. Now we have over a dozen new treatments, even more coming. And many of them work in the majority of patients, and they work for years. So I think his prognosis is actually pretty good, that we're going to be able, his doctors will be able to keep his cancer in remission for years, maybe 5, maybe more, 10 years. And he's 82. Nobody lives forever. But as long as the cancer can be under control, he may live, close to his natural lifespan. Now, the real problem is that the treatments do have side effects. Like hormonal therapy makes men tired, it can cause hot flashes and other side effects, muscles weaker, etc. So quality of life can be worse. And that is exactly why if he had had a chance to get rid of the cancer earlier, it might have still been better. But there's a lot of things that can be done to keep his cancer under control. And that story, by the way, is, even though he's a former president, it's not an uncommon story. I see patients like this all the time. And we have these amazing stories of men doing really well for long periods of time. And that's not something that I saw at all as much of years ago. So, and that's because we have better drugs. We have better understanding of who to treat aggressively and who to leave alone, like those molecular tests I told you about earlier, or even the Artera test, that AI test. And, I think we understand more about how to use the tools we have in our toolbox. And so I predict that he'll be treated for years to come, and that his quality of life should be good. Maybe not as good as if he got rid of the cancer and we found it earlier. It was found earlier, but still okay. And well, obviously I wish him well, and I hope he does well, because cancer is a common enemy for all. We do not want anyone to suffer from it.
I know that you're also involved in cancer prevention. And this will be my last question. This has been, by the way, thank you so much for this conversation. I've learned so much. And I know that people that tune into this podcast will also learn a bundle. Um, Cancer prevention. It's sort of on the other side, and there seems to be more of a push for it. I know that, my father, in addition to many other doctors I've talked to, are, you know, pushing cancer prevention, at least in the families of patients that they've treated. I wonder if you could say some words about, cancer prevention in conjunction with, like, yes, we better manage, but in terms of families of people with cancer, um, maybe some conversation that you have with them.
Well, I mean, one of the most important things we know is that there are different risk factors for different cancers. And one of the risk factors is that if other members of your family have specific cancers, it may increase your risk of getting it. You don't have it, but if your mother had breast cancer and your father had prostate cancer and your aunt died of ovarian cancer, that is a red flag for the fact that you might have inherited a gene or more than one gene that might increase your risk of getting cancer. So we know more about those hereditary risks, those genetic risks. The most famous genes are related to the BRCA1 and 2
Right.
genes. But we also know that they only account for a very small percentage of all the risk factors because they're just not very common. So, so what are you supposed to do if you come from a family where there's a strong family history of cancer? It does and should put up your radar to really be careful and monitor for cancer more aggressively and to follow the guidelines, but to make sure that you're seeing somebody who is aware of that history. So we sometimes ignore the family history, but in fact, the family history is very important. The problem, of course, is a lot of people don't even know their family history, or their family history may not even be correct. Maybe they were adopted, and nobody told them. And so it's not always reliable. So there are moves to understand genetic risk more. And in fact, there are these genetic tests that can be done and they're both available, on a consumer level, but I recommend generally doing it in the context of a genetic counseling appointment or speaking to a doctor who is an expert in genetic risk. So if you know you have an increased risk of cancer, let's say because of one of these factors, then the question is, what can you do to reduce that risk? This concept of cancer prevention. And it is really, really important, but unfortunately, there has not been as much research into this area as we really need. I'm
Right.
an oncologist. I treat people with advanced cancer, but over the years, as I've gotten older, I've come to realize that the best way to treat cancer is to avoid it altogether and prevent it altogether. The second best way is to pick it up really early. So if there's a theme to this conversation, it's do everything you can up front to prevent it or to catch it early if you are going to have it. Now, those are both easier said than done, and they require, um, kind of both an awareness when people are healthy and feeling great, um, and not thinking about it. So, that's the difference. It's like if you feel well, how can you prevent a problem you don't know if you're going to have it or not? And there's work being done in this space, and I think we know if you can assess your risk, there are things in your lifestyle, for example, things that I know you and the foundation are
Yeah.
focused on in your Rooted in Health program. Um, whole foods, minimizing red meat intake, um, minimizing dairy. Certain things have been associated uh, with improving or decreasing the risk of getting particularly hormone-related cancers like breast and prostate cancer. Alcohol use. Turns out that there's really no safe amount of alcohol to drink. And, we're seeing a lot of early breast cancer. We're seeing a lot of early colorectal cancer. And we don't fully understand why, but we do think it's lifestyle related. It probably has to do with more processed food, and it probably has to do with more alcohol use, at least in the case of some of these cancers. So, I'm not telling people not to enjoy themselves in life. It's kind of as we approach 4th of July, sounds like sometimes if you're not allowed to have anything, then life is too short. You're like, why can't I enjoy myself? But I think it's really about moderation, and it's really about kind of trying to support studies where we're trying to understand these risks and doing the best you can. But it's particularly important in certain patients, right? uh, Patients who have a strong family history or genetic risk. Those are patients in whom they should be particularly aware of that risk, screen for that risk, and also do everything they can to kind of modify that risk.
Dr. O, I want to thank you for, being part of episode 3 and talking about precision medicine, AI, President Biden, prostate
Mhm.
cancer, all the great things that are happening in advances in treatments and therapies in cancer. So this has been great, and I thank you for taking the time to speak to everyone. Thank you very much.
Of course, Paula, it's my pleasure and always great to work with you and talk with you, and I'm so happy that you're doing well as well.
Thank you, thank you. Likewise, it's always a pleasure. Thank
Thank
you.
you.